those meetings that you had with Peter Marks. Oh, we don't see any signals. We don't see any signals. And we're looking. Well, yeah, because you're masking and they're filtering and this and that. But if you think that's bad, okay, you think it can't get worse than that.
Yeah.
Guess what? So I'm very well aware that things happen in industry.
Right.
Okay. And I said to myself, they can't be that stupid when it comes to these vaccines. Okay. And as I got into it more, I said, oh yes, they can.
Oh.
So if you ask me what's the one thing that shocked me, I think even someone who has a pretty above average knowledge of some of the shenanigans that can happen in the pharmaceutical industry, this surpassed anything that I would ever have imagined someone could.
Let us hope that your work will sow the seeds of change. Welcome to the React 19 podcast, where we bring awareness and support to the COVID-19 vaccine injured and discuss the science, research, and laws that affect all of us. Hi, everyone. Thanks for joining us again today. I'm Ann Forty, the host of the React 19 podcast. And as many of you are aware, President Trump recently tweeted that he wants to know definitively what the safety and efficacy are of the COVID vaccines. Today, we will be discussing this very topic. And here to help us do that is accomplished and recognized expert, Dr. David Wiseman. Dr. Wiseman's newly published research paper suggests that the FDA and CDC may have missed thousands of potential warning signals in VAERS, including myocarditis, strokes, clotting, neurological symptoms, and more. He highlights serious flaws in the current detection methods and calls for full transparency and an independent investigation. Dr. Wiseman has been working in the field since 1996 as a PhD research bioscientist with a background in pharmacy, pharmacology, immunology, and experimental pathology. He was one of the top 66 research scientists at Johnson & Johnson, where he headed up a research and development program overseeing preclinical and international clinical research, including pharmacovigilance. Dr. Wiseman, thank you so much for being here today.
Thank you very much.
You have critically important data to share with our audience today, and because you are an expert in the field of research methods and data, and most of our audience is not, what I'm hoping can happen is that your research and findings can be presented in a way that any layperson can simply understand so that they will be able to share it with their peer groups and communities. So let's start with the title of your paper, since it really captures the essence of all we'll be discussing today.
You see it? That's good.
Yes. So here we are.
Well, thank you very much once again. And this is a complicated subject. We're going to try and make it as easy as possible and break it down. So please fire any question at me. This is what is called a preprint, so it is not a peer-reviewed work. And as you mentioned, the title, I tried to get everything in the title. Let me dive into what's going on here, because that's probably the easiest thing. So we're going to be talking about signals. A signal is a way of determining whether, I think everyone knows what a VAERS report is now. Is that a fair?
Yeah, I mean, I'm assuming everybody is, but that's the Vaccine Adverse Event Reporting System. So
okay.
Anyone can report either themselves, doctors, nurses, medical professionals are supposed to do it. They're actually required by law to do it, although there's now a whole lawsuit.
Certain circumstances, yeah.
There's actually a whole lawsuit against the fact that hasn't been done. But just so people know, that is supposed to be the place where people can report any adverse events, and that the FDA and the CDC is supposed to be diligently looking at those. And that's what we're talking about, that maybe
right.
Didn't happen.
Okay, and I'm sure, especially to the React 19 group, who I absolutely tremendous work, Bree and Joel and everyone else. The criticism is, VAERS is not causal, you can't infer anything from it, and so on and so forth. And what my work is what I'm going to describe is that's really a sort of a misdirection answer. People need to know why that is misdirection, and if I don't fully explain that later, you'll come back and make sure I do. So the idea is that that once someone makes a report to VAERS of, let's say, a myocarditis or a small fiber neuropathy or whatever it might be, okay, associated with a particular vaccine, that on its own doesn't prove that the vaccine did it. But once those numbers of reports get to a certain statistical number, and we're going to describe that, what that means in a moment, that becomes a signal. And a signal now means, oh, it's like a flashing light on our dashboard on your engine, warning light or something like that, saying you better check this, the oil, the gas, or whatever it is. Okay. And FDA and CDC is supposed to analyze signals and then make some determinations about what to do from there. And what I'm going to describe is that the signals that they were generating, there were lost signals for various reasons. I'm going to use three words which I'll explain later. And the three words are truancy, masking, and filtering. And I'll explain that in a moment. So let's just give you, I've tried to break it down, summarize everything in a very short sentence, in a less short sentence, and a slightly longer sentence that people can use perhaps. And if you can come up with better ways of saying this, I'd love to use those as well. So the very short summary of what I'm going to tell you is that hundreds of COVID vaccine safety signals were lost from FDA's empirical Bayesian analysis. That is one mathematical method of analyzing all the VAERS reports and determining whether or not there is a statistical signal. I'll explain that in a moment. The slightly longer version of this is that hundreds of COVID safety signals were lost in FDA's empirical Bayesian analysis due to three things: truancy, masking, and filtering. And the slightly longer version of that is that hundreds of COVID vaccine signals were lost from FDA's analysis. And these represent, this is really important, still mostly uninvestigated potential risk that FDA was legally required to consider without needing to determine causality. And that is really, really important.
Really,
and I'm going to explain to you, and again, please grill me on it, why that's important, because everyone says, oh, you need to, you haven't determined causality. No, they did not need to determine causality. Once we got a signal, that is called a potential risk, and that should have gone into the equation, and it didn't. So that's why this is important, and let's see if that becomes clear, and if it doesn't, you'll ask me a question. So I'm going to go through, again, very slowly, what we're talking about. So a statistical signal is declared when the number of reports in VAERS for a particular adverse event Y, let's just say myocarditis, after drug or vaccine X, just let's say Moderna, I'm not picking on anyone particularly, right? But it has to be this event with this vaccine. So it's a particular event vaccine pair. That's the terminology. Okay, and once the number of reports reaches a certain statistical criteria, which we don't need to go into the mathematics of it, but once it reaches those criteria, then that's called a signal, a statistical signal. Okay, and once we get a statistical signal, we can say that now we have a reason to suspect that drug X may have caused adverse event Y. So now it becomes a suspect. It doesn't mean that it's proving that the suspect did it, right? But further investigation would be needed to establish that indeed drug X did cause adverse event Y. So at the moment, it's still a suspected adverse reaction, but it's still there. Okay. And so these statistical signals are safety signals. And I can sort of, again, later on explain why FDA tried to sort of say that wasn't the case, which was wrong. They're safety signals that represent potential risk. That's an important regulatory word. It's not just my word. Those are regulatory words, right? That FDA is required to consider for an emergency use authorization. I think everyone knows what that means, unless you want me to explain it, without needing to establish causality. Okay, so these are the foundational ideas that you need to understand before we go further. So we're good so far. Yes?
Yeah.
No?
So basically, just basic level here. So if someone, through VAERS is reporting a pulmonary embolism,
Right.
and you see that again and again and again, and if you see that enough times, that should register as a statistical signal.
It's not just the number. There's some other calculation that goes into it. It's like there's a percentage, there's a rate, there's some other statistical things that happen. It's not just an absolute number. No, it's not that, oh, once it gets to 100, then boom, you have to compare it against something. So there's a statistical thing that happens in order to determine whether 100 or 1,000 or 3 is statistically significant. In order for it to become a suspected adverse reaction. So it's not just the number on its own. It's with some other statistical.
It's based against those other variables. Okay.
Other statistical calculations.
Yeah, right.
Okay. Okay. Now, what happened was that there's two main methods how FDA and CDC do these calculations to determine whether or not there is a signal, a statistical signal. And one method is called empirical Bayesian data mining. Okay, that's a very long term. Okay, it doesn't really matter.
Can you really explain that, what that is compared to like regular, data mining? Like what does that really mean to the layperson? Can you explain that in a very simple way?
Again, there's a calculation that takes, in very simplistic terms, the number of reports, right, for a particular adverse event pair. So again, myocarditis, Moderna, for example, and it compares it with the in some fashion, it makes a rate out of it. So you always have to know how many events are occurring divided by the number of people that got the drug. Okay, so let's say, just going to make easy numbers. Let's say 100 people got the drug and 10 people got this adverse event. Okay, so the rate would be 10%. Okay, in this easy number. So that would be Moderna. Let's say we looked at all other vaccines, right? And all other vaccines, 1 out of 100 people got this adverse event. That would be a 1% rate. Okay. So you have a 10% rate for the, and I'm just giving easy numbers, examples, but that would be that you had 10% in the vaccine of interest, let's say Moderna, and 1% for all other vaccines. So you have 10 times, 10 divided by 1, 10 times more in terms of 10 times higher rate of the occurrence or reporting of this particular adverse event for this particular drug. Okay, so that's what we're trying to do. That we're trying to get that type of number for many reasons, which are going to be way too complicated, I think, to discuss here. We can't actually do that calculation, but we do other calculations that are generally accepted as representing the ideal calculation. Okay. So the empirical Bayesian data mining is one way of doing that type of representative or substitute type of calculation from the one we would really like to make, but for various technical reasons we can't. Is that okay?
I hope that's sufficient. I was trying to look for something like really easy, but I mean, you did with the 1 in 100 versus 1 in 10. I guess is it? And I think you talked about it. Is it the PRRP?
Okay, that's another way. That's another way of doing it. I mean, it's a very similar method to the empirical Bayesian data mining. Okay. There's pluses and minuses of both methods. Okay. But basically, they're trying to do the same thing. Where it gets into the weeds is that the empirical Bayesian data mining uses lots of the PRR method is anyone can do as long as they've got some basic understanding of it. You can do it on a Microsoft Excel spreadsheet. Okay. But the Bayesian data mining requires some quite sophisticated computation plus $100,000 a year subscription to the software.
Okay, I guess. Well, let me just ask. So if the PRR, so it's showing. Oh, okay. I've got 1 in 10 for Pfizer, again, made up numbers, and 1 in 100 for Moderna. What would be the difference that PRR is telling you versus Bayesian? Like what would PRR be picking up that Bayesian doesn't, or what does Bayesian pick up that PRR doesn't?
Okay. So the Bayesian method, I mean, this is really getting into some, I mean, this is an excellent question. So the reason for the Bayesian method is that when you have small numbers of case counts, let's say we gave 10 out of 100 just to make easy numbers, but in practice we're talking about millions of doses, millions or tens of thousands, hundreds of thousands of people that have had the drug, and let's say 3 people get a particular adverse event, or there are 3 reports for a particular adverse event. Okay, with new drug, let's make it 6. There are 6 reports for the new drug for myocarditis, let's say. Okay, but that's 6 out of, not out of 100. That's 6 out of tens of thousands or hundreds of thousands of people. Okay, so can we really detect that 6 is really significant? Because the background, if we look at all other vaccines historically, let's say, we can only find 3 events out of also tens or hundreds of thousands of people. Okay. So do we believe that the difference of 6 out of 100,000 or 3 out of 100,000 is statistically significant? And this is now getting into a whole branch of statistics where statisticians argue about this all the time. Right? When you're looking at very small numbers of cases, okay, there's all sorts of weird statistical things that happen. Okay. And so statisticians argue about that all the time, and they're trying to make adjustments or corrections, because there's a lot of noise that happens at those very small number of case counts, those 3 and 6, those sorts of numbers, as opposed to hundreds of cases or thousands of cases. So the Bayesian method was designed in part to try and correct for noise that happens at that very low end of case counts. So when you're trying to determine whether 6 is really a signal over 3 out of hundreds of thousands of people that got the drug, you could be off very easily because there's noise. So this empirical Bayesian data mining does all sorts of statistical stuff.
Okay, I think that's helpful to know.
Okay, so
that's good. No, that's good.
Okay, you're good at that. I mean, the truth of the matter is that okay, at very low case counts, 3, 6, maybe up to 10, you probably need something like that, because there could be legitimate noise that we can't, we've got to have this balance between, well, if we get false positives, that's not good, but if we get false negatives, meaning there's really a signal but we're not seeing it, so you have to sort of balance between erring on the side of caution. Okay, so we'll generate a few things that look like they may be signals but they're really not, as opposed to not picking up anything but that's really there. Okay. And so this is always the statistical problem in any type of statistics. Doesn't matter what it is, this included, that there has to be this sort of balance between these sorts of considerations. And that's a tough thing. So, but when
I think we've established here that you know what you're talking about, because you know all this, you know all the intricacies and the nuances, and because of that, that should make us more trustworthy of the data, because you know how all of these things can be represented or misrepresented. So I think that just gives anybody listening in, okay, this guy understands what he's talking about. He knows how things can be calculated or miscalculated. So I just wanted to make sure people understood.
Yeah, but I also point out, I know how the system could be manipulated as well.
Right.
So people could take that in the other way, and that's where the rubber meets the road.
Exactly.
That's the problem. You've really hit on the absolute crux of this whole matter. It doesn't matter whether we're talking, safety signals or vaccine efficacy or any aspect of of the vaccine story, or any safety story for that matter, is that scientists have to really look critically, carefully at their data, and even if their intention is not bad, they've got good intentions.
Right.
Okay. But even scientists can be fooled by their own data and their own biases, even though they're not intending to deliberately misrepresent anything. And that's
why we need scientists talking and no censorship. And
that's right. That's exactly right. Yeah. So, but yeah, you've hit on the matter. So I hope I didn't make that too complicated. I mean, once you mention the word statistics, a lot of people just sort of, they sort of close down. So I hope I got it. Anyway, so what was supposed to happen was this: was the FDA was supposed to analyze the data every week. As more and more data was coming in, they were running these analyses, and they were sending out reports from within the FDA to other FDA people and to CDC people, and every week they were saying, okay, here are the adverse events for which there are currently statistical signals that we have detected. Okay, and these reports went out week by week, and the CDC was supposed to do the same thing for the other method that you mentioned called PRR, which we'll talk about a little bit as well later on. And of course, we would expect that all these things would be subject to, be publicly disclosed. There were FOIA requests by different people for different parts of the data. And finally, after a bit of a fight, Aaron Series group and the ICANN group was successful in getting a FOIA release back in January of this particular type of analysis, the Bayesian data.
I think that's important for people to also know. Okay, FOIA is a Freedom of Information Act, and it took like 3 years to get this data. So the FDA, the CDC was fighting it. I think Marty Makary, current FDA director, just recently said, he was saying how when they got in, even when he got in, they were trying to get this data, and they still wouldn't give it to him, which is why some people had to be fired because, I'm not saying, this happened, the data that you got came in January, but they're still, RF Kennedy Jr., others have been trying to get data. The FDA, the CDC are still not releasing it. And finally, it's like, okay, well, we're going to have to fire some people so we can get to this data.
Right,
and I just think people should know that there has been this fight to get data. And I guess that leads to a question. And I think you've answered this in another interview as to what data. So the public has access to VAERS. People can go look at the VAERS reporting system. They can see all the, 1.5 million adverse events that have been reported and all this. Again, not causation, just they can just see that. But what is it what did this FOIA data show us that was not in VAERS?
Okay, so as you said, anyone can go onto VAERS Wonder. There's a website, and you can do different searches and you find how many adverse events of this type, that type, whatever, for different vaccines and so on. And you can also download as a data file the sort of raw data. Mm-hmm. And if you've got a little bit of, you understand how to do that sort of thing, you can actually do some of these analyses yourself. Okay, so the PRR analyses you can do yourself. Most people can do, who know a little bit, because you can do it on Microsoft Excel. The Bayesian data mining is much more tricky, and there's two ways of doing it, as far as I know. One is you buy the program, or you buy a license to the program from Oracle, the big computer company. As I said, that costs a lot of money. There is an open source version of that. Obviously, it doesn't give all the features, and in fact, not part of what I'm going to talk about here, but I'll mention it sort of briefly. Is that I'm now working with someone who, we're looking at that open source Bayesian package to try and replicate these results. So the answer to your question is that we wanted to see what FDA was generating. Okay, we wanted to see what their analysis was saying. Okay. Even though we may be able to do our own analysis, and to some extent we have done our own analysis, but how this all got triggered was, I've been doing this safety signal stuff for about 4 years. I published on it, or at least we preprints and that type of thing, going back 4 years with Josh Getzko and others. But we want to see what was FDA seeing, and what were they telling the other people within the FDA, and how is that
makes sense,
informing their decision. Okay. So we could do the analysis, and so our job is to say, well, was their analysis reasonable, or was it not reasonable? And again, the bottom line, spoiler alert, which I've already given you, is that conclusion is no, their analysis was not reasonable for lots of reasons, which we'll enumerate. Okay, so does that answer?
Oh, yes. Yeah, that makes perfect sense now.
Okay. So what happened was that every week pretty much a couple of weeks missing and so on, but what we've got a time frame from January roughly 2021 to about July 2022. So it's about a 18-month period where we've got more or less every week's email that went out, and the email went out to about 10 or 12 people, something like that.
Okay.
Not everyone was on every email, but there was about 10 or 12 people on the list. And the email would basically say, okay, here are the signals for which here are the adverse events for which a signal has been detected. Okay. And in this FOIA release, what we got was a PDF file which had 153 pages of basically emails, and embedded in the body, like the text part of where you write your email, was something like this. Okay, this middle picture that I've got here. Okay, now in the email, itself, like the email heading part of it, it says, oh, there's an attachment, that some kind of Excel file. But those Excel files were not part of the FOIA release. Okay, so I confirmed that with Aaron Siri and Elizabeth Brem that this is all they got was 153 pages. Okay, so just be clear. So I was asked by someone to sort of take a look at it, and as I started going into it more and more, it was like, wow, this we need to talk about this. So what I've got here in the middle is just a representative listing, and I've colored so every line, and I've sort of expanded the bottom section there just so that you can see the words, because there's 124 lines here. So I've colored the Janssen in pink and the Moderna in yellow and the Pfizer in green. Okay, but obviously I can't get all the Janssen signals on there, but I can get all the Moderna and the Pfizer. And you can see that there's only about eight green Pfizer and 6 yellow Modernas, but there's 110 Janssen's, and this is for a particular day, April 29th, 2022.
Okay, and of course, for those of us who've been following this makes no sense, because the majority of people got Moderna and Pfizer. The majority of adverse events in VAERS is Moderna and Pfizer, and yet all these Janssen are showing up. So you're like, how's that?
Okay, so if we stop there, right? If we stop there, you would say there's something really wrong with that.
Yeah.
And we could stop the whole interview now and say, okay, there's something wrong with this picture, right? For exactly what you've just said, right? Okay, and I don't think that, anyone can see that this pink is way bigger than yellow and green, and that's the first thing, and everyone knows that Janssen was used way less than the other two drugs and vaccines, right? And something's really wrong with this picture. Okay, so you don't have to know any statistics, right?
No.
To know that. Okay, it should be clear to anyone. Is it clear? It is clear to you.
It is clear. It is clear.
Okay, there's a reason why I chose that particular date, and I've got, I can show you other pictures of other dates, but we've got this imbalance, this huge imbalance of Janssen over Pfizer and Moderna that persisted for pretty much the whole of the 18-month period that we've got the data for which we've got the data. Okay, and why wasn't anyone asking these questions?
Right.
So the imbalance is between, when you do the range of how much this imbalance is, it's 9 to 22 times more signals were showing up for Janssen than Moderna or Pfizer. Okay, and then when you adjust for the issue that you've mentioned, which is, well, wait a minute, Pfizer was actually being used about 9 times more than Janssen, Moderna about 5 times more, roughly, right? So when you sort of adjust for that thing, then it comes out that Janssen was 100 times more, was generating 100 times more signals on a sort of per use type of basis, right, than the other two. That's insane.
And if they were getting this data, you'd think like, hey, red alert, we need to do something here.
Yeah, they should have been like, whoa.
Yeah.
Whoa. Yeah, exactly. And again, if we stop there and ask no other questions, that would be bad enough.
Right.
Right. But you've hit the nail exactly on the head. Okay. So what? that's actually not the worst part of it. Wait, there's more, you know.
Yes.
So remember I showed you, there was 124 signals. Here we go. That's 124. And you see the red, yellow, blue, and I've scrunched it down into a little bar here. That's the same sort of proportion of red, yellow, blue in that tiny little bar. So that's 124 signals I just showed you a minute ago. Okay. Now, the thing is, but then there was other stuff that happened. Well, first of all, you know, as you said, it doesn't make any sense that Janssen is way more than Pfizer or Moderna unless it was really that much worse. So what I did, because I compared these data with other data from other data sets that we've got in other places to find out what the more logical or plausible ratio of Janssen to Pfizer to Moderna.
Okay, so this is what you were talking. This was, so we're hitting that first point of truancy?
Yeah, this is truancy, right?
Okay, and how are you defining truancy?
Truancy
means to the layperson.
Truancy means that we expect, based on the proportions of adverse events or signals, I should say, signals for Janssen versus Moderna versus Pfizer, we would expect proportions like this picture here, like this new bar that I just put up. Okay. We would expect proportions like that, as opposed to the proportions like the first bar that says 124. Okay. So when you sort of recalculate how many, you know, let's assume that Janssen was the right number, right? Janssen actually could have been more, but let's assume that Janssen was the right number. It's just that Moderna and Pfizer were way too small. When we compare those results with other data sets that we have for other things.
Okay. Wait, let's stop right there. When you say you compare to other data sets, does that mean like, okay, you knew of other studies that were done, and these other studies were showing all these adverse events that, you know, for Moderna and Pfizer that the FDA wasn't including at all? Is that what you're saying? Like these?
Well, I mean, yeah. There's two parts of that. There's two parts of that question, really. The first part is, what is the relative proportions of the numbers of signals that we would expect, you know, comparing Janssen versus Pfizer versus Moderna, based on other data sets and based on the fact that, you know, the usage of the different drugs was different. Okay, so what's the relative proportion? So before we even talk about numbers and what the individual adverse events were, let's just talk about just how many signals do we expect to see relatively of the three vaccines, one to the other. We don't, obviously the first bar, you know, going back to here, this doesn't make any sense. Okay, so what does make sense? So I've asked, okay, how do we know what does make sense? In order to know what does make sense, we compare it to other data sets, which I'll go into, you know, the details of those.
Because that can be confusing, because if we're just like, oh, well, that can't be right, so we're just going to adjust these numbers. Well, it could be right if Janssen was really that bad. So I just want to be clear that, you just didn't arbitrarily decide.
No, we didn't just arbitrarily. And again, so what we're trying to determine is, well, was Janssen that bad, or was it a combination of Janssen? Well, it might have been worse, but not as bad. But it seems like the Moderna and Pfizer signals, these are just as like, and if you look at these particular signals, some of them are not really sort of biological things. Like let's say let's say the bottom, this one here, the fourth one on the Moderna, product administration to patient of inappropriate age. Okay, well, it is an adverse event, you know, that has to be reported, but it's not like they got this medical condition. Right. So, and you see that on the Pfizer, you know, you've got product preparation issue, and that's a usage kind of thing.
Right.
And so on. Okay. So first of all, we're going to ask, are the proportions plausible? And they're not plausible. And what is plausible? Let's go to another database where the proportions look plausible. Compare the two and say, okay, if we got the proportions in the plausible database, what would this database look like? Okay. And so when we do that, we say the proportions should look like this. And when they do look like this, then we would go from 124 total signals to 405 signals, right? And the difference is 281. So somehow or other, 281 signals, all from Pfizer and Moderna, and also actually there's another category called unknown, because in VAERS, someone might report an adverse event, but they didn't know which vaccine they got.
Oh, okay.
So there's an unknown COVID vaccine. So there's a small number of those as well, which, you have to add them if you knew what to one of the groups, but we don't know. Okay, but there's a total of 281 difference in these two graphs, right? And those are what are called truant signals. They just weren't there. They played hooky. Truancy means they played hooky. They went missing.
So
we don't
for whatever
know why.
reason,
We don't know why,
CDC
but it does it. That we expect to see 405. We only saw 124. Okay, and we'll discuss some more details of that in a moment. So are we clear so far?
Yes.
Okay. Now we start to get even more interesting, because the way that this particular analysis and the way that the PRR analysis is usually done is, and I'll give you a more sort of easy to follow example in a moment if you want, but there's a phenomenon called masking. So if you're comparing Pfizer's signals, let's say for myocarditis, against all other vaccines, but if all other vaccines include Moderna, which also produces myocarditis, then the Pfizer signal doesn't look as bad, because in the control group, you've got Moderna. Do you follow me?
Okay, so are we just saying that the control group is just, this is what we expect? So, okay, so there's 30 cases. So if Pfizer gets 32, then it's just a wash?
Right. In other words, let's say Pfizer has 30 out of 100 to make easy numbers, right, of myocarditis. Let's say Moderna has 25 out of 100. Okay, make easy numbers. And let's say all other vaccines, not Pfizer, not Moderna, not Janssen, have 2 out of 100. Okay. Now, if I compare the 30 out of 100 for Pfizer versus 2 out of 100, that looks like a pretty big difference, right?
Okay.
You with me? And if I look at Moderna and say, let's look at Moderna 25 out of 100 versus the everything else 2 out of 100, that also looks like a pretty big difference. But if I add the Moderna's numbers into the everything else numbers, now I've got 30, and I'll show you a better way of saying this in a moment. Now I've got 30 Pfizer against 27 out of 200, all everything else, but that includes Moderna. So the Pfizer.
Wait, you lost me there. If you're adding 30 to 20,
you're
adding 30 to 20.
I'm going to jump ahead. I'm going to jump ahead. Okay.
Sorry.
Okay. So let's jump ahead. Let's jump ahead. Right. Okay. I can give you a vaccine example or a rat poison example. What would you like? Okay. Let's see what works better. Okay. Well, I'm going to give you the easy one. This is the rat poison number. Like, imagine comparing the toxicity of hemlock, arsenic, and water as rat poison. Let's say. Now, compared with water, hemlock and arsenic are equally toxic. Okay. But if I combine if I combine the data for arsenic and water together and compared that with hemlock, now the hemlock and arsenic don't look so different from each other. They look equally safe.
Okay, got it.
Step by step, you got it, right?
Right. Yes.
Okay. All right. So now, when we adjust for masking, because this Bayesian method did not adjust for masking, we find there should have been another 365 signals on top of what we had before. So now we've gone from 124 to 770 signals. Okay, because if we adjusted for that masking problem, we should expect to see 770 signals roughly.
Right.
Okay. With me so far?
Yes.
Now it gets better.
Or worse.
Or worse.
Yeah.
Because in addition to that problem, the threshold, I'll explain that in a moment, they chose an inappropriate threshold, meaning they made it harder than they needed to for a signal to show up. So imagine you've got your engine light, your fuel light, your gas gauge on your car that makes a beep, right? And you want to know with good time, when you're going to get empty. You don't want to know at the last minute,
right,
that you're empty. So you set that you could set. Let's say you could fiddle around with the controls of your gas gauge, and you say, listen, when it gets to a quarter empty, make a loud noise, right, and make a big flashing light. Okay, so you've set the threshold on your gas gauge at a certain number. Okay, well, if you set your gas gauge instead of at 25% empty, right, you only set it at 10% empty, you have to wait a lot longer before your warning light comes up. And and 10% gas, you might be on a long trip and you really would have preferred to have known
that there's not a gas station for 200 miles and you should have, you needed to,
so the threshold in that example is, sort of the other way around, but the threshold is that they set the threshold too high, meaning it took more reports or more statistics.
They actually set it really low, like, they
set it high. They set it
high. Yeah.
High.
Yeah. Okay. So it wouldn't pick up the signals.
It was less. It took a lot more to pick up the signal.
Got it.
By setting the threshold too high. Okay. So we call that filtering.
Okay.
Okay. We filtered the information, so only the really, only when it got really bad, right, or worse, that did it sort of show up. Okay. Right. So
it's like they were intentionally looking to avoid these things. It seems like there was an intent to not look for these things. And I think that was really clear in, obviously when you had the injured from React 19 sitting down with Peter Marks, and he's like, oh, they're presenting him with all this data, all these people. Right. And he's like, we just haven't picked up any signals.
Well, and I've got those quotes, from the React 19 website, with all those meetings that you had with Peter Marks. Oh, we don't see any signals. We don't see any signals. And we're looking. Well, yeah, because you're masking and they're filtering and this and that. But if you think that's bad, okay, you think it can't get worse than that.
Yeah.
Guess what? There's another line. Now, I've colored it gray because it's not quite the same as the others. Okay, so what if you get a borderline signal? Okay, well, actually, before we get to that, before we get to that. So what's supposed to happen at this point is that FDA is supposed to, if a signal shows up, so okay, let's look at this. Let's make sure this is really a signal. Let's make sure there's no confounding issues why this is showing up for, it could be a genuine false positive. There could be some statistical quirk why it's showing up. It really shouldn't have shown up. Okay, so they have to do some more stuff to determine whether or not it's causal. Okay, and certainly they did that. All right, but what they didn't do is they said, well, what about the other way? The other way is, what if there were borderline signals that weren't actually signals yet, but they were hovering around the sort of magic numbers. Okay, some of those negative signals could actually be false negatives, right? But really, if on further investigation, would have actually shown to be actual positives. Okay, so there could be borderline signals that they didn't show up in the red, yellow, green, but they weren't equally zealous.
Okay,
they were zealous in hunting out. They were zealous in weeding out the false positives. Okay, but they weren't equally zealous in weeding in the false negatives, and that's a statistical bias. Now, the number I've got there is total is 580. Obviously, not all of those would have shown up as the signals, and I can't tell you what percentage it would be. But it could be 1, it could be 10, it could be, I don't know what number it is. But they weren't. The point is they weren't doing it. Okay, so I call this an inquisitorial triage bias. Okay, so they were doing an inquisition on these. Right, on the ones that did show up, but they weren't doing an inquisition in the ones that might have been there, but were hiding.
Got it.
So statistically hide, not because anyone was deliberately trying to hide.
Right.
Okay. So that's the overall picture of what we've got. So now, again, in this very summary, and I'll go into as much detail as you want. You decide. This is a sort of summary slide. So again, I've repeated the title here. So now you see that we're getting a loss of signals of about 763 signals, okay, because of these four reasons. Truancy, there are three reasons: truancy, masking, and filtering, plus these sort of borderline things, right? And through other analyses, again, if you want me to go into it, that's fine, but you can read about it in the paper.
Right.
All right, it could be up to nearly 7,000 signals, safety signals, that they were lost from FDA's empirical Bayesian data mining. Okay,
over 7,000,
nearly 7,000
safety signals.
Correct.
Like 7,000 different adverse events?
Adverse event vaccine pairs. So in other words, it's like Moderna plus myocarditis. That's one. Pfizer, Moderna plus Pfizer. That's two.
Over 7,000.
Nearly 7,000.
Wait, I thought I heard you say somewhere that somebody got 24,000.
Okay, well, okay, that's okay.
We don't have to go there if you don't want to.
No, I will. Okay, so okay. Okay, okay. Let me just go real quick, and then you can cut it out if it's too complicated. Okay, let me go to real quick. Okay. Yeah. Okay. So this actually gives you the provenance of all the data, which data sets I got from where. I'm not going to go into the columns, but basically this red box here shows you 763 signals, the 763 that I just showed you a moment ago. Okay. I've got other ways of slicing and dicing the data, looking to check my number. You always want to check your number by doing other analyses to see if I'm way off. If I do the analysis this way or that way, do I get very different numbers? Do I get similar numbers? So what I'm showing you here is a bunch of other sort of analyses of a similar type, but I did some sort of variations in what I did to see if that 763 looks reasonable. So if I do this set of analyses indicated by the black box there, I get a range of between 487 and 1,898 signals lost, which is, again, the variation seems like a big swing, but given that, we've got a lot of uncertainty, that's a pretty narrow range, actually. You might think it's a wide range, but whatever it is, it's a lot. Even if you take the lowest number, 487 signals, that's still a lot of signals that are lost. Okay, there's another analysis that I'm basing it on CDC did this other kind of method called a PRR analysis, and they came up with 778 signals. Wow. They were comparing. They combined the Moderna and Pfizer together and compared it with everything else. So it was sort of a demasked sort of analysis. Okay. I did the same analysis and came up with 1,900 signals. Wow. But again, we're in the same general ballpark as 763. There's another way I did it, and there's another database called a violin database. Again, if you want me to go into it, I will. But there's something called the violin database, and by directly interrogating that database, we also came up with 5,000 to 6,000 lost signals. Okay, and then the 24,000 number, which you mentioned a moment ago, is that there's a paper by Harpaz, and I use that in a lot of the analysis as well. And I'll explain who Harpaz is in a minute. But in there, they looked at VAERS looking at US and foreign reports. The FDA only looked at US reports, and there's some pluses and minuses to that. It's not necessarily that one is right or one is wrong. They really should both be reported, frankly. But in this Harpaz paper, they actually reported, as of October 2021, they reported 24,000 signals. What I've done here is I've just sort of scaled it back because I said, okay, some of those are foreign, because there were foreign reports and so on. So I scaled it back to 18,000, but still. So if you took Harpaz, either the 18,000 or 24,000, that's a lot of signals. Yeah. But it's way more than my 763. So Harpaz, if you take them as being really super credible, and I think they are really super credible for the reasons I'll mention in a moment, whichever way you do this analysis, there's a lot of signals that are missing. So do you want me to give you the provenance of Harpaz? Because I think this is really important.
Okay, well, if you think it's important, then yes, I would like you to.
Yeah, because you're going to be blown away when you see this. So I know we're jumping around a little bit, but this is really worth it, actually. Yeah. Okay. So all these analyses that I've done have been primarily based on these three sets of data. Okay. So we've been talking about, that big yellow, pink,
Right,
yellow,
right,
green
right.
picture, right? So that's this FOIA in EBDM, empirical Bayesian data mining alerts that we've just been talking about, and then also CDC PRR analysis were also released as well at different times. So that's our focus of our investigation. And I told you that we were comparing the different ratios and the plausibility based on other data sets. And the two data sets that I used were these two: the Oracle data set, which was published by Harpaz, and this violin data set. So the Oracle, who are Oracle? Okay, well, Oracle is the well-known computer software database company. Okay,
Hmm.
and the authors of this paper, the first author was Harpaz, but the second author was a person, Dr. William Dumichel, who was the inventor or the developer of this Bayesian data mining method. He is a statistician. He invented the method.
Okay.
Okay, so if anyone knows how this stuff
Yeah, he would
works,
he would know.
he should know. If
Yeah.
he doesn't know, we're in big trouble. Okay. Okay. Also on that paper are a couple of people who either were or had been retired or were currently, I think they still are, at FDA. One of them is, if you can see the small
Mhm.
writing there, the last author is Anna Schaafman,
Yes, I see that.
Scarman. Okay. And she is a very senior, accomplished biostatistician, FDA, and she and Dr. Michel have been working together for years, going back to at least when they were developing this Bayesian data mining, and which was sort of done with, like, there was a collaboration between Oracle or an FDA or whatever at the time, and she was like the FDA champion of the method,
Oh, wow.
and then brought the method into the FDA about 25 years ago. Okay.
Okay, so the FDA uses this then?
The FDA, so the Oracle has a software, again, you can buy it for $100,000,
Right.
called Empirica. Okay, that's the software that they use, and Harpaz et al., including Sharpen, wrote this paper. And just to be clear, that even though there are FDA people on this paper was 2022, the FDA people said, well, yeah, we're not writing in our official, FDA, we're writing in
Roll.
our personal sort of capacity.
Okay.
This is not an official FDA
Right.
paper. So this is a pretty credible source that I'm relying.
Obviously. Yes.
Okay. So you agree with that? Okay.
Yes.
And the source on the right is, we call it the violin data set, and there's a website that you can see there. You can go to, and it's a website, and there's some couple of papers that were published. The violin is an acronym for vaccine something network, and it was a project at the University of Michigan, partly or fully funded by the NIH. Some of the people from NIH are on the paper. Okay, and you can go to that website and you can look up, this vaccine and this adverse event, and it will spit out what the PRR value is for
Okay.
that particular combination. Okay, so pretty credible. Um,
Yes.
and I have actually been in touch with I had a couple of questions, and I was in touch with the authors, the main author of this paper, and he did respond to me, and we had a nice chit chat sort of thing. And so those are the two. So the provenance of what I'm talking about isn't like someone's website that they've just put
Right. Right. No,
a
that's
back
good that you
a back of the
clarified that.
envelope sort of calculation. I'm using very, very well provenanced data or
Yes.
analyses, or whatever you want to call them. So where we were a moment ago was, we were here before we took
Right.
that detour, and you asked me about the 24,000.
Right.
So we agree there's a lot of signals, for one reason or another, just weren't there. Okay, there's no plausibility to
That's
those.
just very suspect. I mean, I'm sorry, but it is. And obviously, now that we know, I don't know that you can find anybody who either hasn't been affected by an adverse event themselves, or they know somebody who's been affected. And so,
Right.
I mean, I feel like your data just matches up with the real world,
Right.
the real world data of just
Right.
what's happening.
Okay. So the next bullet point is, and this is really, really important.
Really important.
People have to understand this, and this is like the misdirection. I think again, whether deliberate or others, but you've heard a zillion times, oh, VAERS is not causal. You can't infer anything because it hasn't been proven to be causal that this drug causes this adverse event. Okay, well, in the law and in the regulations around emergency use authorizations, FDA are required to consider not only actual risks but potential risks. Okay, because the standard of the EUA was overall was lowered from a regular type of FDA type of approval. Not only was the quality of evidence didn't need to be as robust in terms of procedures and all the scientific stuff that has to happen, right? But the quality evidence didn't have to be the same. So FDA for efficacy only had to reasonably believe, that's the term that's used, that the drug may be effective. Okay, they didn't have to prove or establish that the drug was safe and effective. And how many times did you hear,
that's all we heard.
This is safe and effective? No, that was not the regulatory standard. The regulatory standard was that based on a totality of evidence, which could include very, not very good quality data that we wouldn't normally consider. We had to reasonably believe that the drug may be effective, and for safety, we had to make a determination the benefits and potential benefits outweighed the risks and potential risks of the drug. Well, once you say potential, well, who determines what potential is? I mean, those are very gray areas. Okay. But once you generate a statistical signal, then you cannot deny that is a potential risk. Okay, you can say, okay, well, a raw VAERS report, okay, it's just a report. We don't really know what it is. But once you convert it to a statistical signal, or once it shows up as a statistical signal, then you have an action that the FDA is required to do. Is like, okay, let's investigate it. But now it becomes a suspect. Okay, as like a suspect in a crime. It's not like a person of interest. Say a person of interest doesn't sound so bad, but once a person's a suspect, right, there's a different connotation there. Okay, but so they did not need to establish causality. Okay, and if they ignored potential risks, then they weren't doing their job.
Right, and I think that's an extremely
people don't realize that. So
I don't think so. Everybody, safe and effective. Say, nope.
Right.
I fought at my local health department only because the county commissioners, they were very open to the critique of what I was saying. Hey, all these things are missed. And they said, hey, can you put together some adverse events or, if not? And then that was given to the health department. And the health department was like, nope, we've already covered all this. This is, it's very sad, very sad.
It is. And so what I just described to you a moment ago was that the different standards were applied to the assessment of safety and efficacy. It was okay to consider, not very high quality or convincing data for efficacy, but oh no, if it's safety, we have to be absolutely certain. Right? There's a big difference there.
And because of this, because this wasn't known, or because this wasn't allowed to be seen, obviously that had an effect on, what they said might be caused and then might be allowed to be considered for COVID vaccine injury compensation. We know that they have rejected, 97% of the CICP claims. And I want to read this. I am in a group with people who are either vaccine injured or trying to get information out on the vaccine. And you may know Heather Hudson, her son Cody, at 21 years old, he took the vaccine. It's been tragic. He's had, oh my goodness, I have a list here of all the things that have, embolisms, DVTs, his lungs were bleeding, just he's basically dying. Anyway, she had texted our group, and I have permission to share this. She texted our group last night because she was really excited. She's like, oh, we're going to go and see this new oncologist. We're really hoping he can help Cody because nobody's been able to help him. And this young man is basically dying. RFK, actually, there's a video of him talking to Cody. This was several years ago. And this is what she's texted this morning. And because I want people to understand the reality of what the vaccine injured are facing, because the previous FDA, CDC, NIH did not acknowledge this. So this was the text. We just left the oncologist. Cody's case is too complex for him. He wanted to refer to the state specialist, University of Florida, Shands. Last year, Shands referred Cody out to rheumatology as his case is too complex. The rheumatologist referred him to Florida Cancer and Hematology. They could not get approval for rituximab immune modulation. We tried again with a different office of Florida Cancer and Hematology for plasmapheresis, and after driving an hour and a half and filling out all the forms waiting for the doc, they said his case is too complex. The doctor said to go to Shands. We told him Shands referred him out as the case is too complex. He said he has no solution. Cody is heartbroken. Pray for him. We are all heartbroken. Yeah. This is the reality of tens of thousands of people who are literally stuck. They have nowhere to go. They have no help because of your work here, because all of these safety signals that people are living with that have not been recognized, and therefore patients go in, they get gaslit, nobody believes them. No, well, we would have heard if this were an issue, or no, and because you had Peter Mark saying, oh no, we're not picking anything up. Here they are, and they are in distress, and they are dying. And it is unconscionable. It is just unconscionable that this has happened. And
you're absolutely right. I mean, all the people I work with are exactly in line with what you just said there. And for FDA, so we don't see signals. And I'm going to give you some of those quotes from those meetings to just to make sure people have got them at their fingertips. It's one thing for you to say, but I'm going to, if you don't mind, I'll put it up on the screen if you've got a moment. But obviously, this is the bottom line: that all these anomalies impugn the reliability of all these regulatory decisions and all the compensation decisions, right?
Yes.
And there's a little box here on the top in the middle here. VAERS is the nation's early warning system for vaccine safety. So when they want to tout VAERS as being, okay, on the one hand, it's not causal, you can't do anything, blah, blah. By the way, I just got this paper rejected. I sent this paper to a very well-known journal I sent it as a, what was the word? Pre-submission inquiry. I didn't actually formally submit it, but I sent it. I'd been in correspondence with the editor of this particular peer review journal, who for months had been asking when is your paper going to be ready? When's your paper going to be ready? So finally I sent it to them. And I said, look, I realize this is a bit controversial, so I'm not going to submit it yet, but I'm going to send you this as a pre-submission inquiry, right? And they said, okay. And they wrote me back a polite letter, and they said, oh yeah, well actually it's theirs, and causal and blah blah blah, and reliable. Really.
Yeah, well, that's supposed to be the number one top. Oh, we'll collect everything, and we have this great surveillance system, and then they actually collect all this data, and it's like.
Yeah, but here's VAERS is that this, you can quote, this is FDA or CDC saying VAERS is the nation's early warning system for vaccine safety. Doesn't look like it. Okay, I'm going to give you some examples of this sort of double speak, because I think people need to understand the double speak that's gone on here. Okay, and even as I've been doing this for a long time, and I read things, and I you take things as read, and then you realize, wait a minute, there's double speak here, and you don't get it. So I'm going to give you examples of double speak that people need to be aware of. So I told you about, I used the word suspected adverse reaction earlier, right? That's a real term. Okay, that appears in the Code of Federal Regulations to do with investigation of new drugs. And as a definition, and it's, if there's a reasonable possibility that there's evidence to suggest evidence to suggest the causal relationship between the drug and the adverse event, that's called a suspected adverse reaction. Why are we calling them signals when really it's a suspected adverse reaction? Well, maybe it's easier to say signal than suspected adverse reaction.
Right.
Okay, it is easy to say that, but guess this is what it hides. It hides the word suspected. Okay, that's huge, right?
Right.
You agree with that?
Yes.
And just to show you, just that I'm not completely, off my rocker here. I'm going to prove it to you. This is the VAERS system, which is like the drug version of VAERS, right? And I took a screenshot like a couple of weeks ago, and you can see the green highlights, but they've used the word suspect product name, suspect, active ingredient. They use suspect all over the place, right?
Wow.
How come we're not seeing that in the vaccine?
Right.
That's really, they are hiding the fact that these are suspected adverse reactions. Okay, we're not saying they're causal, but they're downplaying that it's even a suspect. That's big, isn't it?
Yeah, I think in addition to that, you think of the people who signed up for VSafe or whatever, they didn't even have, there were only certain things that they could put in as an adverse reaction, like sore arm, whatever. There was no place for like chest pain or neuropathy or all these things.
I think they could do it as a free text. They could enter it as like other.
Yes, and of course we had that data had to be fought for as well. But I think too obviously all the injured I have interviewed who, their reports never got in, their doctor never submitted it, or they went in and they couldn't find their VAERS report. We don't even know. There has been a study saying that, there's so much underreporting that, only 1% of adverse reactions actually get reported. But I don't even know how we could do accurate data given how much I feel just deception was taking place, and just
that's how you feel lied to and everything.
There's no like, oh yes, we'll look under every rock and we'll turn over every stone. No, you didn't.
That's exactly. And I'll show you that quote. I've got that exact quote. So okay, I think we've covered this, so I'm not going to go through this again. And this is just showing you, this is the standard operating procedure for VAERS, that these type of analysis were going to be done. So this is showing you where it comes from. I'm not even going to attempt to go through this unless you want me to.
We're running. We're already over an hour, so we should.
Okay. But here's another one another double speak here. You see this box over here. I'm only going to talk about this one. A statistical signal. This is FDA in there. When they're sending out these emails, that were going out every week, in the first few emails, the people sending them were giving sort of some background information about how all this works, and they say a statistical signal of disproportional reporting. That's this statistical signal that I'm talking about is not a safety signal. Okay, that's a not equals sign. Okay, so they're trying to. So it's bad enough that it's a signal, not a suspect adverse reaction. But again, even a statistical signal is not a safety signal. So in other words, when Peter Mark says we don't see any signals, well, he's sort of trying to put his hand on his heart and say, oh yeah, I'm telling the truth. Well, that's, it will come as no surprise to you that is not exactly accurate. Okay, because I've got some examples where clearly, where is it? Here, this one over here. It's in the VAERS SOP. Clearly, these are safety signals, okay?
Yeah.
Why are you saying they're not safety signals? So they're even trying to mischaracterize these statistical signals as being safety signals. What? It's a signal of a signal, so it's therefore not a safety signal. This is just complete 1984 doublespeak. This is the excerpt from the Food and Drug and Cosmetic Act. I just want to draw your attention to the bottom part. I mentioned known and potential risks. So this is in the law that they have to consider potential risks. Okay, I'm going to jump way ahead, and this is just, I've shown you that picture before, but this is other examples of other weeks, so that I didn't just cherry pick one week out. But if you look over week by week, the blue here is the Janssen, the green is Moderna.
Yeah.
But this was persistent for weeks and weeks and weeks. anyway, and this is another representation of that. And when you adjust it for the different usage that you asked me about at the beginning, you get nearly 100 times more signals for Janssen. If that was true, then Janssen should have been taken off immediately. Okay, but what actually happened is that Janssen was actually still giving more signals, I think, realistically, but it was, I'll say, only 4 to 8 times, which is still a lot. Okay, but not 100 times.
Right,
or 20 times.
right.
Okay, but it wasn't just in the number of signals; it was in the range of signals that the FDA was reporting. There was only 13 unique signals that propped up from Pfizer, only 11 unique signals for Moderna, 140, which goes off the page here for Janssen. So there's something very wrong. Anyway, I've shown you this whole analysis. We found some of these signals showing up in that Harper's paper. They detected signals that the FDA didn't. And I've given you this example already, so I'm not going to go there. And then in the Harper's paper, this is really another really important point. We talked about masking. So the main focus of the Harper's paper was to talk about masking. And they were talking about a version of their Bayesian analysis. Remember, I told you that Michel was the inventor or the originator. Okay, so they actually developed a sort of a modified or an upgraded version of the Bayesian method to allow you to adjust for that masking problem that we talked about. Mm-hmm. Okay, and it's called RGPS. It doesn't matter what that means. Okay, but this is a screenshot from the software documentation that when you buy the Oracle Empirica program, included in the program is the ability to look for masking. Okay. FDA had this version or a later version of this. Why weren't they using it? Right?
So I wish you could have a private meeting with President Trump and present all this. And I just, where there's going to be a Senate hearing tomorrow, trying to, get Kennedy out. He's not going to be able to be there to defend himself, but it's just going to be all these doctors and officials saying why he should be, put out and to resign, and nobody will be there to present the other side. And because of that, people are dying. People like Cody. So many people,
and many more Codys and Maddie Garays and
Maddie DeGarry and Bree and Joel and Shelley and Lindsay,
everyone,
and, the people who've lost their children, Ernesto.
Yeah, sure.
So I think there was a holding out of hope for those who are vaccine injured. Like, okay, RFK is going to get in there. He knows what's happening. I've personally talked to Jay Bhattacharya. He knows about the vaccine injured. And so I think those who are there, McCary, Bhattacharya, RFK, they all want to do something, but there's this whole industry that wants to shut them down. And I just pray that industry does not succeed, because I personally feel that that's going to lead to such despair. Like, if these people, like, their hope is in Kennedy and, the Bhattacharya being able to get something out so they can get help. So that is their hope. So if that's wiped out, I fear for
a lot of people.
Yes, I fear for a lot of people, and I fear that their hope will be gone. And we can't let that happen, which is why it is so important that your data gets out there and people understand it and can share it with whoever. That is my call here, is that people would take this information, they would share it with friends, family. Again, go to your send it to your county commissioners, your health departments, your senator, your congressman. I've gotten very involved with the politics and working on people's campaigns that I know believe in what you're saying and what you're presenting. And, so, they're going to get this. And so I would encourage everyone to share that. And I guess I'd like to ask you 2 questions. One is, as we close out, what have you been most shocked or surprised at within your industry, within the work that you do? What have you been like, whoa, this really surprised me, over the work that you've done? And then what is your call to the listening audience?
Well, I haven't until COVID. I hadn't worked in vaccines. I'm working in another area. In fact, I have a paper that just came out, an invited editorial in the Journal of American College of Surgeons. It just came out last week. So
okay, and we'll link all this. We'll link everything in the show notes.
Right. So I had no preconceived notions about vaccines, or I wasn't a quote unquote anti-vaccine, and it's a terrible.
It is a terrible term. It's used asking pejoratively.
It should not be used. I mean, it's really
right.
it's really disrespect. People have tragedies in their family, but we don't necessarily know why. But they shouldn't be further suffering by being called names. Okay, we need to get to the bottom of it. So I have no preconceived notions about vaccines, but and I actually took one dose of Pfizer, and I said to myself, they can't. And I know what goes on in the industry. I've seen stuff happening in industry, and in this editorial in the Journal of American College of Surgeons, I write about stuff that happened in my area of expertise, and how all that's got to be, what the consequences of that has to be in terms of that particular area. Okay, so I'm very well aware that things happen in industry. Right. Okay, and I said to myself, they can't be that stupid when it comes to these vaccines. Okay, and as I got into it more, I said, oh yes, they can.
Oh.
So if you ask me what's the one thing that shocked me, I think even someone who has a pretty above average knowledge of some of the shenanigans that can happen in the pharmaceutical industry, this surpassed anything that I would ever have imagined someone could do. All the inconsistencies in the data, the lack of data scrutiny on the part of FDA. I've got and then just to, I know we're going to, so I'm going to show you very quickly just the title. That's all I'm going to show you of my other paper that just came out, a preprint yesterday, 2 days ago, which you can put in your links.
I will.
But this is a massive paper, okay? And there are 248 regulatory style questions for the FDA in this paper that talk about all the manufacturing and safety testing issues that just were not handled appropriately. That's just putting it very mildly. I did this work with Maria Gucci, who's I just certainly want to acknowledge her for the very extensive collaboration and very fruitful collaboration with her for the last couple of years. But everything I think you need to know is summarized in this title, is that oftentimes in the various regulatory documents, either in the guidelines or in the FDA documents or in the company documents, they might be trying to justify why a certain test isn't going to be done, why they're not going to do a certain type of safety test or a certain type of analysis or whatever, and they might say, based on blah blah blah, we expect that this is not going to be a problem, right? And they use the word expect, and they don't provide any justification. If you can put the word expect into your answer, all of a sudden that's the magic answer. Okay. Yes. So that's one thing. And then of course there's a over generous reading. They're quoting, this based on this guideline, we don't have to do blah blah blah. Well, if you read the guideline, that doesn't actually say what they say it says. Okay. So so I've gone through things to do with DNA contamination, to do with safety testing, to do with frameshift proteins, to do with the fact there was actually, in my opinion, 4 processes for the Pfizer, not 2. You've heard of process 1, process 2. Right, there was actually a 3 and a 4. Okay, right? Multiple things that happen here, and there was the person from Pfizer who was interviewed a couple of years ago by the journal Nature. And she was boasting, and the headline of the paper is, "We flew the plane while we were building it.
Yes, I remember that. I remember
Right?
that.
And it's like, really, that's your boast? I mean, it's just no, no. There's just so many things. I just want to end just to show you. You mentioned the no stone is to be unturned. I'm just trying to find that quote from Dr. Nair. Really, here we go. This is so. I just want to. If you're going to end shortly, but here's the part of the transcript for one of the React 19 meetings on January the 4th, 2022, with Dr. Marks and Dr. Nair. And they're constantly saying, we don't see signals, And he said, and Nair says, the direction that I've received from Dr. Marks is to leave no stone unturned to look at this very vigorously. Well, clearly, if you're setting the threshold too high, clearly, if you're not dealing with masking, there's a lot of stones that that are still need to be turned over. This is absolute rubbish.
I'm sorry. Go ahead.
And then particularly the questions were focused on neurological issues. Okay, and so what I did is I pulled out all of these signals. There are about how many? Here we go. Neurological. So out of the violin database, depending on how you do it,
right,
I came up with 403 neurological signals that the FDA could have, would have, should have seen. Even if you use the worst masking and the worst threshold, they should have seen 126 signals, right? Even by that standard. And and I couldn't get. I mean, so what the hell are they talking about? They're saying, oh, there's enhanced surveillance with no stone unturned. This is complete rubbish. I mean, this is. I'm sorry. This is complete rubbish. What on earth are they talking about?
It's shocking because we know that in January of 2021, they were flying vaccine injured out to the NIH, Bree and others, to study them. They knew all these issues were happening. Oh, yes. Oh, we're going to let people know, we're going to help you. And then what do? They don't say anything and they ghost the people. That was our FDA, CDC, and NIH. I mean, like, the public doesn't know that these people were flown out in January 2021 because there were thousands of, I think Denise Hertz has an email from somebody at the NIH saying, oh, yes, we're aware of thousands of safety signals of this happening. I mean, this is, again, unconscionable.
Here's another example. I mean, cancer. I mean, that's come up.
Oh,
and,
yeah.
And I've been involved in work on this topic, and I testified in the Texas Senate last year about cancers and did work with Carlos Allegra and Yuri Nunes in Ed Dowd's group. We looked at cancer rates and so on. And then Peter Marks testifying in, when was this, a year and a half ago, in the House, we have not detected any increase in cancers with the COVID-19 vaccines. Well, okay, here are signals. Here are signals in the PRR data set, right, that CDC had put out, and then on the right-hand side, on the left side, is from my analysis, there's cancer signals. I mean, we can go through lots of other types of signals.
Yeah, we'd have to do a whole nother.
So there's a ton of, and of course, when they knew this, I mean, this whole story about myocarditis, and they were putting off acknowledging myocarditis. But this is just a progression of, this is FDA's analysis of myocarditis and pericarditis from this empirical Bayesian data mining from January to October 2021, that they didn't find any signals. But the Harpaz Oracle people did find a signal for myocarditis in the orange there that started in May. But that's using the conventional criteria. When I took away masking and the threshold filtering issue, then the signals are showing up way earlier. And then I'm not expecting you to read any of these boxes, but I'm showing here all the statements, all the meetings, and all the things that happened when they say, oh, we don't see a signal yet, we don't see this, we don't see that. Then they authorized the children's 12 to, and this was all accessible to them weeks earlier. Shocking.
I just hope the truth can come to light. I just hope the truth can come to light because people's lives are hanging in the balance.
Yeah, but we're fighting for science here. I mean, this is just a complete perversion of science. I'm sorry.
I mean, what would be your charge or your last parting words to the audience?
You got to get this data out to, to your congressman, to the president, to support all the people that are trying to do good work here. Senator Johnson, has been remarkable.
Yes.
Really. But there needs to be more people like that. You've got my website.
Oh yes. Where do people contact you?
So at the very beginning, I've got this is my adhesions.org is my Twitter thing, and and you can do that, and then there's an email address there, david.wiseman@synechion.org. But once you get into my Twitter, you can see one of the recent tweets is a 2.5-minute video.
Yes, that's very helpful. I'll put a link to that in the show notes as well.
Yeah,
that was a very helpful.
I mean, you asked some really good questions, and I hope I did explain it in a reasonably.
And if somebody wants a really condensed version, you did a great job.
The 2.5-minute video, and I did cheat. I did put it up at like 1.1 speed.
Yeah.
But you can slow it down. And so you can read that, and then you can look at the paper. I put an abstract, a capsule, so there's like a small version, a slightly bigger version. The rest of the paper is very, very technical, and it's meant to be technical. So that's not for the faint of heart, but
it can be shared with the doctors in your life.
You can share it, and you can just print out the first two pages, and if someone wants to read it, and then this paper, the other paper that I mentioned, is actually even more encompassing, because it goes into a whole more. I mean, this safety stuff is just one part of the bigger picture. I mean, so we have to address all those other manufacturing issues, which I have delved into with Maria, Gucci, and others. Yeah, we need to get this out. And then if people are interested in supporting our work, I would love to hear from them as well, because this is a ton of work here.
Yes, well, I cannot thank you enough for just putting. I can't imagine the thousands of hours that you've put in, just to help your fellow man, to help.
This is a massive amount of work.
Yes.
Massive.
And so anybody who's listening, get it out there. Anyone who can help Dr. Wiseman, please contact him, and let us hope that your work will sow the seeds of change. So thank you again so much.
And thank you for all your work, and Bree and Joel and the thousands of others that are working with you. So thank you.
All right, we press forward. Thank you.
Thank you.